Hey everybody, I'm Dr. John Willardsen, and we're here today, here in beautiful Newport Beach, California. Our live stream September 20th, 2023, and I'm here with Memo, and we're going to talk all things dental implants and oral reconstruction. So today I'd like to review, now that I've met this patient. We initially met on what was it, on Zoom, I think it was, and he lives on the other side of the country. So when we first initially met, I had received a few x-rays from the doctors that were working on his case, and had a pretty good idea as to what was going on. But until I see the person and see the patient, see exactly what's happening, I don't really know. And so what I'd like to do today is just kind of talk about, one, his situation and how he got into this situation. And it's really an issue of the system more than anything. It's not an issue of the doctors managing his case. It's because in reality, you don't know what you don't know until it's too late. And so let's take a look at, and this poor guy has he's been without teeth for about 4 years now. I'll show his initial, bear with me as I scroll through here. I'll show you his initial x-rays, which we talked about this case a couple of live streams ago, but this was how he presented initially. When I look at this x-ray, so what we're seeing here is a lot of old restorative dentistry, root canals, bridges, missing teeth, extractions. So, basically when we look at his x-ray here, the only place he can chew is right in the front. And so the doctors that were working on him back on the East Coast, thought it would be a good idea to place a couple of implants on the upper left-hand side. It's reversed, the x-ray again. It's the L on the lower left here. That's the left, so it's actually opposite. So on the screen, it looks like it's the right-hand side. But anyways, on this guy's upper left-hand side, they placed some implants without really knowing where they're headed. When I look at this case, and if I have a clean canvas, immediately I'm thinking extract all the teeth, get the implants in the exact right position. But first I have to know where I'm headed. I've got to know what the prosthetic design is going to be. Because if I don't, I end up in a situation like this is at now. Because the ultimate outcome and the ultimate design is what dictates the placement of the implants and the anchors that are going to support the prosthetic. And so here it was a bit random. They were just putting in implants, pulling teeth, adding more implants, and not really having a comprehensive plan to help him, because he has very high demands as well. He knows what he wants. And so if there's not a whole lot of margin for error, and it was just so happened that they kind of picked the wrong guy to practice on. And so let me pull up his, okay, so here's the original x-ray. Apparently they had, and I don't know what date this was, but they removed these upper left teeth, placed implants. Again, when I look at this, I immediately go to, let's just get these teeth out of there. There's nothing left here to save. My rule of thumb there is, if it's not going to be in his mouth in the next 3 to 5 years, get it out. And we can see that with the root canals, and with the root canal, it's like almost like a dead tree. Eventually, it's just going to break down. It's not going to support something that receives a lot of load. What that means is here I've got a bridge that's extending from the second molar, number 2 on the upper right-hand side, all the way over to number 13 on the left-hand side, with a distal cantilever and that cantilever is taking load. He's missing 1, 2, 3, 4, 5 teeth in between there. So with a bridge, you have a connection and then a missing tooth, which is what's called a pontic, another missing tooth, and then a supporting tooth, another missing tooth, supporting tooth. So it's kind of spread in between. Let's see, he's got 1, 2, 3, 4, 5, 6 or 7 teeth supporting technically 14 teeth, right? And so the load factors, especially when you get into root canal teeth, because it is like a dead tree, it's almost, it's very brittle. It's very, it can support something, but more like one itself, like if it's just one tooth supporting itself and not trying to support the load of 14 teeth, that can work. But when you get into a situation like this where you've got all these teeth that are root canaled trying to support an entire arch, immediately my mind goes to, let's get all those upper teeth out, put implants in, and finish the case with implants. But so that leads me to the idea of the design. So knowing where these implants must go in order to provide a end goal or the end prosthetic that's going to last him, for the rest of his life. And if you fail to plan in these cases, like they say, if you fail to plan, you're planning to fail. And that's really what happened here. Because there was no real plan, and that goes, really it falls on the prosthodontist who was in charge of this case. It was a prosthodontist who referred it to an oral surgeon. The oral surgeon basically follows the referral notes or whatever the prosthodontist asks for. And, so in the end, it really falls on the prosthodontist because it's him who is kind of quarterbacking the case. And that's, again, when I say the system is broken, it's precisely that. That's why, having one guy that can't do one part of the procedure, handing it over to another guy that can do that part, but then sending it back to another guy that should know how to do the restorative part. So the system is kind of broken in that way. And ultimately, again, it's the patients who suffer. So, all right, so let's take a look at...
So, doctor, it's really up to the patients to figure this out on their own or just land in the right practice.
It is up to the... Well, again, that's why I say the system is broken, because it's up to the patients, but it's really not, because the patients are going to go off of whatever the original doctor, who would be the prosthodontist in this case, is going to say, okay, Mr. Smith or whoever it is, I need you to go see Dr. So-and-so an hour away. He's going to pull your teeth out. He's going to put some implants in, and then you're going to come back to me, and I'm going to build all the teeth on the implants. And when the restorative doctor does not understand or do surgery or place implants, that is where it breaks. So that the restorative doctor is now dependent on the surgeon to place the implants in the right position, and then the patient goes to have the extractions, implants, whatever, done by the surgeon. But if the surgeon doesn't understand the prosthetic side and what the final outcome is going to look like and be like, he's going to place implants in positions that may not be the right position. And we'll look at that today. Again, I met him on Zoom initially, saw x-rays, but I didn't have all of the information. Now I have all the information. I know now exactly what happened here. So basically, because one guy is in charge of one aspect, it's like having two contractors. One contractor has one idea, the other has another idea, but you're expecting these two contractors to build the perfect house that you have envisioned or that the architect has drawn up for you. But in reality, in this case, there was no architect. So there wasn't a vision. It was a vision from one guy, a vision from another guy, try to merge together. And ultimately, it was kind of catastrophic, really.
And so, I mean, there's plenty of implant centers, and we just specialized here on placing implants. How often do you think this happens when a patient goes to a general dentist or prosthodontist and they have them go to an oral surgeon and do all this?
Yeah, it happens all the time. But 90% of the time it happens and it's fine. It works out okay. But there are cases like this where the patient he knows what he wants. His expectations are very high. And in reality, his thoughts are, I don't care what it costs. I want my mouth fixed almost exactly to how it was before he lost his teeth. And again, that falls back onto the initial contact or the initial doctor, managing those expectations and helping the patient understand, okay, Mr. Smith, your teeth are coming out, and there's, like, for example, and I say this all the time, but one of my greatest fears is losing all my teeth, right? I mean, you lose so much with that. You lose the architecture, gum tissue. And so, you have to, and if I were in his situation, or imagine if you came to me and I said, look, I got to pull all your teeth out, you'd have to manage the expectations of what that means, right? So, pulling out your teeth, bone grafts, implants, temporaries, and all that goes into it. And not you, but a patient envisioning, okay, so you're going to pull all my teeth out, put in implants, give me a final set of teeth, and it's going to cost this much money. And it's going to look, because you've paid that amount of money, you expect it to look and feel and be exactly like it was before your teeth were pulled. So as your teeth are right now. Mm-hmm. And that's just not possible. It's simply not. Again, when the teeth come out, so much is lost. So it's not possible to have expectations that your mouth is going to be exactly the way it was prior to losing your teeth. And so, again, it falls back onto that initial contact. And I actually don't even know who that was, if it was a general dentist, the prosthodontist, I have no idea. But whoever initially diagnosed this case and put the treatment plan together, they claimed that it was a guided surgery. I highly, highly doubt that, and I'll show you why. Guided surgery means that you've pre-planned the case, you have created a template guide that goes in the patient's mouth so that you drill the holes where the implants need to go, exactly where they need to go, so that when the final set of teeth are made, you have the implants are dead on in the right spot where those teeth need to go. They're not off a millimeter or 2 millimeters here or there, because it really does affect the outcome and the overall end result. And so, and I'll show you on this case. So let me go back here. So this is how I saw the patient, the initial, once he got to me. This is the x-ray. So if we look at the position of these implants on this case that was planned out, surgical guides created, and teeth taken out, implants placed according to this quote-unquote surgical guide, and now this is where we're at. And so, and hopefully I can show you. So now I have his models, and I can show you on the camera here. Dennis, I don't know if you can zoom in, but no. And so here is the lower arch, and I've got 1, 2, 3, 4, 5, 6, 7, 8, 9 implants on the lower. And as if we can see here, I've got in this spot right here, I have 2 implants that are in the canine position, and 2 implants. So two implants on one tooth. So 2 implants here supporting one tooth, 2 implants over here supporting one tooth. And so when we look at the x-ray, these 2 implants here and these 2 implants right here are, so these 2 here and these 2 over here, they're so close to each other that they're basically, I have screw access holes coming out of one tooth. So the canine, so number 22 and 27, 2 implants supporting that one tooth. So my point is the guide and the plan was off, or something was off. And then on his upper jaw, I've got an implant here that's literally right in between his 2 front teeth, so right at the midline. And it's a small diameter implant, and it's sitting like towards the palate. I think it's in the incisive canal, which is not a big deal, but I would have gone a little more lateral, this way or this way. Pick a side, pick this tooth or that tooth, push the implant one way or another, because right now this implant here in the middle is completely useless. In fact, yesterday I took it out, so and added an implant over here. So I added an implant here, removed this implant, bone grafted this site where the implant came out, placed an implant in the number 10 position. So now I have uniformity, I have balance. I actually ended up placing an implant back here on the right side to give him more support in the back. And so we've kind of had to add a few implants in order to make this prosthesis long-term viable. As it was, because he again, the patient has very specific wants. He knows what he wants. He doesn't want any pink porcelain. He wants everything. So almost as if it's almost like just replacing his teeth. And so I had to add implants and do some other things in order to make that happen. So, all right, let's see. So let me show his.
I have a question.
Yeah,
as well.
yeah.
Hello, I'm considering dental implants. Should there always be an extensive treatment plan? One time a doctor told me we don't need a plan, and there was something called all on 4. What is that? Oh, okay, so pretty much the question saying is there, kind of like what we've talked about before, is there always need to be a blueprint plan? Because this person, she's saying that, she went into a place and they just said, we're just going to do all on 4. So.
Yeah, that, what's her name? Kimberly, that's a great question. So the question is does there have to be some sort of a blueprint plan? She had gone and was recommended that she have the all-on-4 procedure. So if we look at what is happening right now in the marketplace, is like Kimberly was saying, even in this case, they probably initially proposed to him that to have all-on-4. And I'm so glad she asked this question, because had they done all-on-4 on this patient, for one, they already have their hands full. But had they done an all-on-4 on him, he would have been absolutely miserable and would not be a happy camper. And they would really, really have their hands full if they were to have just done the standardized Clear Choice, M4 Implant Center, Nuvia, all-on-4. This patient would be absolutely miserable. He would be, yeah. So you have to size up the patient, understand what exactly it is that they want, and then come up with a treatment plan and a plan that will meet those needs. It's really, really important. So, yeah, that's a great question. So, and she says that they say you don't need a plan. We'll just do an all-on-4. That's kind of the standard. In reality, with an all-on-4, I mean, even then you do need a plan, but I see so many all-on-4 cases that are not planned, implants kind of randomly in different positions. The angulation of those implants is very extreme. It's usually for patients that have very little bone or lost a lot of bone. But in a case like this, where I have literally a clean slate, he's got tons of bone, still has some teeth. I mean, and again, we're going to be very successful in this case, and the patient will be super happy. But if I were to approach this with that standardized clear choice all on four protocol, I would be in a lot of trouble. And so every case needs to be looked at with the eyes of what's best for the patient and long-term what's going to be the most successful result. Again, it's one of the best investments you can make. I say that, just whatever the amount of money it costs, and then 5, 7, 10, 12, 30 years down the road, your mouth is still together and still intact. There's not a whole lot of other places you can invest and still have the investment paying back every single day, to have your teeth restored, confidence restored, your smile back, ability to chew and masticate your food. It's a great way to invest in yourself. So, but it's got to be done properly. These venture capital all on four centers are trying to take a really delicate, intricate procedure and dumb it down and make it so that everybody can do it and everybody can have it. And that's just not the case. I mean, it's very, again, I have to deal with the patients that end up with complications and problems. And so I hear kind of the horror stories. I don't see a lot of the successful all-on-4 cases. I usually just see the ones that are really, really frustrated. So I know there are some that have been successful that, that's great. Patients are happy with it, and that's good. What you don't know, you don't know. So, but in cases like this patient would not have been happy with an all-on-4. So, all right. But so we can look at, his, so here's the before photo. Again, he had been in this situation for, he says 4 years. I think, I would imagine that's the case, meaning that he has the implants. He's got, so let's see, he's been in this state, unrestored, implants placed, I think for about 4 years. So what's taken so long to get him teeth, I'm not exactly sure. And so here's some photos. And let's see here. So this is how he presented to me. And these are the implants. So this implant right here, I should have flipped this around. Shoot. Anyways, this implant is right in the midline. In fact, you can see, here's his nose, the tip of his nose right here. This is what we call the midline. It kind of splits your face right in half. And that implant sits right dead smack in the middle of the midline. So it should have gone either one way or the other. I mean, pick a side which side you want to put it in. But right here is one of the most difficult places. One, because it's hard to clean and maintain, and it's just the diameter of this. It's a 3.5, so it's a small diameter implant. So it's not very useful at all. And so I actually removed it yesterday. And so just to kind of give continuity to the case, and then I added one right here so that the bridge here has 4 implants supporting it, and then in the back we've got 4 implants supporting, or 3 on each side supporting those bridges. So, all right, let's see here. So here we've restored the case. This is just temporary; it's not the final, but now at least he's got some teeth, and this is where I start to learn more about him and what he wants. If I were to be critical, which I am, this canine right here is long. It's a bit long, so, but this is temporary, but now I can start to mitigate and deal with some of the issues. Okay, the canine's a bit long. I need to shorten number 6. So that's not a problem. That's easy. But at least now I have a template and I know where I'm headed. I've got a path of, to the final. Granted, if I look at his lower, hopefully we have pictures of the lower arch. Maybe not. Anyways, on the bottom, oh yeah, here we go. On the bottom, so these 2 implants right here, so these 2 implants are right next to each other, and in fact, the camera won't zoom in, but this is the version of the temporary. So I've got 2 implants on this tooth, and then 2 on this one tooth here, and that. They should have moved it over, so I have an implant here, an implant here, an implant here, and over here. But again, it was not planned out that way, and I would say it's the prosthodontist, I guess, who is the quarterback of this case, who says, okay, I want this many implants, I want them in this position. They say that the surgery was guided, so in that guided surgery situation, they would have a guide that would drop an implant here, 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 right exactly where you want them, and not be off a millimeter or 2 on both on those. So not the end of the world, but it does create a situation where, okay, we have to kind of a workaround. We got to get creative with how to deal with these 2 implants that are literally almost touching.
Got one more question from Kimberly. She's asking how much time passes between the temporary and the final prosthesis.
Yeah, that's also another great question. So, Kimberly, that's a good question. And it varies per patient. So, again, if I look at this photo, I don't know this. Oh, sorry. Let's see. Until I get to this point, I don't know what I need to change. And so some patients, I can leave them in temporaries for 3 months, 4 months. Some patients, we go less, maybe a month and a half. It takes from the time of milling, because this is all computer-generated CAD design, and then we have a milling machine that mills out. This was milled in what's called PMMA, polymethyl methacrylate, and it's basically plastic. And so we mill out the PMMA first, which is the plastic version. And then once we know, like in this case, the canine's long here, so I got to adjust that in CAD, move things around slightly, not a whole lot. And then once I make those changes, I will actually mill out another PMMA so that the patient can wear it. And I don't go to the final until I know that I'm spot on, until I know that, okay, now patient's worn it for a bit and he's happy. He was actually thrilled with this, so I actually kind of noted this. The canine was a little bit long right there. So to answer your question, Kimberly, the time from the temporary to the final, probably the fastest would be about 6 weeks. And a lot of these companies, and again, I like to show these details and the intricacies of these sometimes complicated cases, because how in the world could you turn around and turn this case around in 24 hours?
Yeah.
There's just no way. I've been doing this a long time, but you really have one to put everybody in that 24-hour box that everybody's getting their teeth in 24 hours and market that. But every patient is so unique and so different that I would never dare market that every person is going to get their teeth in 24 hours. Or even, the teeth in a day, which is, so when I make the hole and put the implant in, let's see, I think I have video. I'm not sure, but let me see here. So when I'm placing implants, it's loading. But anyways, so to answer your question, Kimberly, it all depends on the patient, the treatment plan that I've given to them, number of implants, bone density, sinus grafts, bone grafting, healing of grafting. There's just so many variables. It can be 3 months to finish. It could be a year and a half, could be 2 years. It just kind of depends on the case, you know. And so, you know, we can look here at, so here so this is where I'm actually removing that center implant that's in the midline. And I was shocked because I've removed quite a few implants. I've never, because I haven't dealt with Straumann much at all, Straumann implants. And I was shocked at how easy this thing popped out. It's been in there for 4 years.
Oh, wow.
Implant's been integrated into the bone for 4 years. And I kid you not, I put maybe 150 Newton centimeters of torque, reverse torque on it, and it just popped right out. So probably integration, well, and it was in the upper jaw, and it's in the front of the upper jaw. That bone is much softer. I think it was actually inside the incisive canal. There's a nerve that innervates the 2 front teeth, the incisal nerve. So they probably removed the nerve and then placed the implant in the canal, but it's right in the midline, so I couldn't use the implant, so I backed it out. But my point is, so implants have each company has, like, for example, this is the SLA, or I think you use the SLA Active, which is supposedly a faster integrating surface. So you have the titanium rod, and then different companies, and I spent 3.5 years studying implant surface texture and implant surfaces, because each company has a different surface that claims, well, our implant integrates faster and longer and better. And the SLA Active was actually a lot of literature by Daniel Buser and other authors way back in the day that, you know, they're all paid by Straumann, so it's not like they're doing some great service, but, you know, they're going to write an article and write literature that will say, oh yeah, the SLA Active is a much more, it integrates a lot faster than, you know, at the time it was for Noble Biocare was Tight Unite was their surface texture. And at the end of the day, I mean, and that goes into, okay, so you're talking about the surface of the implant. What about the material of the implant itself? What's it made of? And that, you know, in this case, this is an alloy. This is an alloy. What we use is commercially pure grade 4 titanium. And the amount of torque it took me to remove this, it's a narrow platform, so it's a 3.5 millimeter implant. So maybe not the best gauge, and it's just one case. But this thing came out really easy. I was shocked for being in the mouth, and in fact was supposed to be, in theory, used in the final prosthesis. So here I'm building this beautiful new case on a foundation that's, to me, you know, a little bit questionable, you know, because I torqued this thing out of there. And I thought for sure, because it had been in there for 4 years. So we use a burr that's called a trephine. And a trephine is basically the diameter of the implant. And it's got these shards on it, or like teeth on it. And I just drill along the long axis of the implant, and then I can remove it because I'm removing the bone that's integrated onto the implant. I was almost 100, in fact, I had my trephines out. I was ready to remove this implant by removing the bone around it. But once I engaged the implant with this implant mount, the piece that goes up into the hex, screwed it on and started torquing it, and I'm like, wow, this thing isn't as integrated as I thought. I think I can probably just back it out. And sure enough, I just put enough torque on there and just spun right out and just pulled it out. So I was expecting, with Daniel Buser's Straumann SLA Active surface on these bone level tapered Straumann implants, I expected the integration to be much, much higher, and it wasn't. It was not. In fact, when I looked, I have pictures of it, and when I looked at the surface texture, to me, it looked like one of the knockoff implants, like Implant Direct, or Blue Sky. The titanium looked like that after I pulled it out of the osteotomy or the site. So again, I mean, we're talking about things that are very, only matter to the doctor that's doing it, but in the end, it's the patient who suffers because they're the ones who are spending the money, taking the time, driving from the East Coast to California to fix these problems when they've put so much faith and trust in, everybody that's been telling them, well, go see this guy, go see that guy, and then go see this guy. And it's like, at the end of the day, they end up in a situation like this. It's tough because this poor guy has just been bounced all over the place. We now, and it was out of control, completely out of control. He spent so much money, so much time. I mean, the poor guy will just break down in tears over the experiences that he's had over the last 4 years. And so to me, again, it's a failure in the system. It's a failure for these doctors to not have proper training, to not take this serious, and to look at every case like it's an all-on-4, or let's just throw implants in there and then let's get the guy out of the office and send him over to some other guy to deal with the problems. That's where it's broken down, and and this is a classic example of where he has suffered. He's been here now in California for like 5 weeks, and because I didn't know anything about the case until he was physically here, but now that he's here, I'm kind of reversing the reel, so to speak, going, okay, all right, now I get it, now I get this, now I get that, now I understand what we need to do for his case specifically. But for him to be here in California and having had spent the last 4 or 5 years dealing with this stuff, it's just, I don't know. To me, it's a really horrible situation. But anyways, it is where it is now. We have control of it. We're now getting him to the point where he is on a path to completion. And, he has a certain personality, and one doctor threw him out of his practice. He's like, I won't see you anymore. I'm not going to deal with you. And that's just not right. I mean, you can't start something and then not finish it, right? I mean, especially taking as much money as he did from this patient and not refunding it and ending up throwing him out of the office. I mean, that's just a travesty. And it shows that this doctor truly did not know where he was going. The case was completely out of control. He knew that, and his way to deal with it was to throw the patient out of the practice. And then so now that's how he's ended up in California. And ultimately it goes down to the doctor's core, that he did not know what he was doing, still doesn't know what he's doing, and got himself in a situation that really doesn't really affect him because he got paid, but it affects the patient. So, my suggestion to him would be to just not, stay away from the implant world if you're not versed in that. If you don't know how to manage these cases, just stay away from it. It's not worth it. We know how much heart tissue we have to burn to manage these cases on a daily basis. I've done my due diligence. We do know how to manage them properly. And if you're going to get yourself into these kind of situations, I would say just stay away from them, So, but anyways, a little bit passionate about this because I've had to I've had to unwind and kind of get this guy under control, and that's, and it can be a challenge, but it's a pleasure to be able to get to the point where we got a patient like this who's just at his wit's end, and now we finally got it under control and we're able to get him completed. So, and this will last him. This will be a great end result for him.
Yeah, no, and this is great to show our viewers and just people who are looking to get dental implants, so then they don't have to go through the same thing that he went through, because he's from where?
He's from back east.
From back east. And you're saying that he's been here for 5 weeks and he
drove here.
Drove here. And he's
didn't
had
fly.
Surgery, I think it was yesterday, right?
Mm-hmm.
And
we've been working on his case for 4 weeks, and it got to the point where I needed to add implants in positions where they should have been, but they weren't. And then I had to remove the one that was in the midline. Just a few things that, I wanted to make perfect for him so that when it's all done, he'll just be done with this and he can put it all behind him. But, he spent a lot of time, money, and effort getting to this point. So.
Yeah, it's just the stress of thinking that he was going to get it done right the first time, but then now 5 years later, he's having a...
Still dealing with it.
Yeah, having a stress about
and still spending money to getting it fixed, when... And that's the thing. You asked initially, like, is this the norm? I think that's what you had asked. I don't really know, or who's in charge of this case. And ultimately, like I said, I mean, it falls on that original doctor. I think it was the prosthodontist who had referred him to the oral surgeon to place the implants. So that first point of contact is the person that is in charge. If he refers you to somebody else because he doesn't know how to place implants or doesn't do that part of it, he's still responsible and in charge for the case. He's the one that has to dictate, because he has to restore it. Like, I have to restore what was presented to me by the surgeon who placed these implants. And so I need to know where they're going to be, or I didn't have any say in any of this. So but if I'm the one that referred the patient to the surgeon for this placement of these implants, it's my responsibility to be able to restore it and finish it. So ultimately, it's up to me to have it go smoothly. And anyways, and this is it's a good case to present because it's one that has so many intricacies and details, and it has it was out of control. Now it's not, and we've got it back in control. And if you're a patient who's been in this situation or have had implants placed and you're kind of in that state of totally out of control, there is hope for you. There's a way to get it under control. So, anyways, that's it's good stuff. And we're getting deep into this world that is in the marketplace, is being marketed all over television, but they're not telling you a lot of stuff,
Mm-hmm.
And they're all pushing that all on four for everyone is just really not. All on four is not for all. It's not something. Can work in certain cases, but if the doctor has real implant skill set, then he's going to give you multiple options. If they don't have real implant skill set, they're only going to give you the all-on-4 option because that's all they know. They can't offer you anything else. So that's where I would caution patients, is in that scenario where they're only being presented one option, which is the all-on-4, maybe all-on-6 in certain scenarios, but usually it's just the all-on-4. So, but anyway, so yeah, if you've got questions or if you want to comment or post, or you can DM us, we can answer questions privately regarding your case situation. Send us x-rays, images. Happy to help however we can. We are here in California, so we do see patients from all over the country because this is happening all over the country. So we do have to kind of, and we've become well versed at the logistics. So helping people gather the information they need. So once they get here, we can kind of move forward. So anyways, thank you guys for watching. I'm Dr. Willardsen here with Memo. Appreciate your watching this. Subscribe and like. That really helps the YouTube algorithm to help our videos grow and help our community grow so that we can educate patients that are going through this process. I'm Dr. Willardsen, and thank you guys. Thanks for watching.